Hi everyone, my name is Cesar Reyes and my colleagues Eugenia Garcia and Nancy Martinez. Surgery first airway management and aesthetic fault of the patient case report. The planning and managing complex cases often require a multidisciplinary approach to achieve optimal function and aesthetic results. Maxillofacial surgery addresses the craniofacial deformities, improving both airway function and facial aesthetics. Post-surgical orthodontic treatment focus on fine-tuning dental alignment and optimize facial aesthetics. Collaboration between surgeons and orthodontics is essential to achieve the harmonious and functional outcome. Highlight the importance of coordinated multidisciplinary approach in comprehensive craniofacial care. Case presentation. We have a patient, female, 30 years old. Clinical examination, the rest of the photography shows 17% exposure of the upper central incisors. According to Dr. Sarves, the smiling photography revealed an excessive gingival displays up to 2 millimeters. Diagnostic imaging. Given the maxillary facial asymmetry, recommended a computer tomography, CT scan. The diagnostic is a skeletal class 1, significant airway reduction. Despite being a slender build, the patient has a substantial amount of redundant submandibular tissue, contributing to appearance of a double chin. Diagnosis: asymmetric gummy smile. According to Dr. Sarve's classification, the patient exhibits significant visibility of the incisor at rest with 7 millimeter spots. Compared to average is 1.6 millimeters for her age. Dr. Dewey phrase, we have three-color assessment system, rate her excessive gingival displays as a red and her buccal corridors as green acceptable. This analysis highlights the need for a multidisciplinary approach to address her conditional, functional, and aesthetics aspects.
The treatment plan in consideration for surgery first approach. We did 9 steps. The step 1 is align pre-treatment dental models to approximate a class 1 occlusion. Step 2, assess overbite insurance at least 1 millimeter of incisor overlap. Step 3, evaluate the molar open bite and the second end level. Step 4, assess the transverse dimension. Step 5, conduct comprehensive evaluation of maxillary crowding. And step 6, position the upper incisor vertically, anteroposteriorly, and transversely in the space. Step 7, assess the inclination of the upper incisors. Step 8, evaluate the occlusion plan of facial convexity. And step 9, determine the need for gingivoplasty. Case approach. The first step was orthodontist preparation. 1 day before the surgery, we'd use a PIX 21 orthodontist with SAP bonding. The second procedure was the surgical highlight for 1 osteotomy close to the infraoral canal and extending to the zygomatic bone. We did an implantation of 5 millimeter, 4 millimeter of the left side and 6 millimeter of the right side to correct the asymmetry in the gingival display. And also did a 2 millimeters the maxillary advance along with a counterclockwise change in the occlusal plane. Also, we did a 7 millimeter advance of the mandibular body, resulting in a posterior open bite of 4 millimeter. This was fixed with bicortical screw intraoral. Finally, a 3 millimeter advancement gingivoplasty was performed, fixed with interfragmentary screws. Post-surgery, the patient was monitored for 4 hours and then discharged to continue post-operative care at home. The last step was orthodontist management. During the orthodontist consultation, we accelerate the change of the bore arch in the big maxillary sequences from 19 ultrasoft to 2020 beta, taking advantage of the patient loss of significant crowding and the benefit of accelerate bone metabolism from the surgery-first approach. We did not start with a 0.4 broad maximizing the surgery cost. Immediately, 2.5 ounce box elastic were used from start to finish. The first case is just 6 months, allowed us to process to the aesthetic phase and place composite veneers in the upper sector. This is the result of the initial and final pictures after surgery. The conclusion, the surgery-first approach represents a paradigm shift in orthodontic surgery, justified by the patient-centered treatment strategy. This method can reduce treatment duration for sometimes patients where significant orthodontic movements are not required. Skeletal arches, this approach provides a mechanical advantage, enabling the implementation of these techniques in the most dentofacial deformities. Active post-surgical metabolic activity is crucial, adding the peaks